And I will ask the question so people can say it on the chat already so that we can all get a sense. How many of you are nurses? And anyone from another discipline, please write which discipline and we will get a sense, because just so you know, we did invite all the other disciplines to attend because we have a spectacular speaker, which I will introduce briefly. And in saying that, I also want to start with a big clap for the spectacular speaker, because she just defended her doctorate. So she will tell us all about that before she starts too. And we are approaching 430 already, Susan.
Great. Well, welcome everyone to our COVID-19 webinar series. And today our topic is COVID-19 vaccine, a game changer. And so Doris is going to start us off in just a moment with a welcome and setting the stage. And then we're delighted to have Dr. Cora Constantinescu, who's going to talk about vaccine hesitancy and effective vaccine communication. We'll have time for questions and answers, and then some final comments and calls to action. And to participate today, we'd like you to use the chat box, and you can put your comments in there or ask questions. And we are recording this session, and we'll provide it for your future use if you want to look at it again or share with your friends. And just about the Q&A, we do want to make every effort to answer all of your questions, but the chat box gets very, very busy. So we may not get to your specific question. And especially if it's captured in the presentation slide deck, we're going to be posting that, or on our portal, we might just put some responses in the chat box for you. So I'll hand it over to you, Doris, to welcome and set the stage and introduce our speaker.
Fantastic. So welcome everybody. And I think that Dr. Cora, we will call her, is competing with Dirk, who presented on the vaccine rollout in Ontario, because by the time that she will speak, we will have 500 people. So here you go. Let me give you a little bit of background about the aspects that we are dealing with as we speak. Well, we just reacted, by the way, to the announcement of the province related to the opening of the economy and the opening of the province, etc., etc. And let me tell you the aspects that we have reinforced, and you will see a statement pretty soon out. We are asking the Premier to not reopen gray area businesses till March 3rd. As you know, he said that we will reopen on February 22nd. February 22nd is only 6 days after we reopen the schools in the same areas. And we are asking the Premier to push it out to March 1st at the very least, so we can see what happens with the school reopening, especially given the 3 new variants present here in Ontario and in Toronto for sure. We are concerned that if that's not the case, we will see a 3rd wave of COVID-19 in Ontario. The other piece that we are urging the Premier is to not allow movement between regions, so that at the very least things get more contained. That's not the case at this point. On the good side of the equation, the Premier did say that decisions, if things change, will be made very quickly, directly going to cabinet table, which I want to believe it would mean that if things worsen, that we will not be waiting 2 weeks until a decision is set. Nonetheless, we are still going to insist that at least 2 weeks between the school reopening on any specific region and the business reopening is prudent, and that we go 1 step at a time. I said you will see a statement soon, but those of you that tweet, I will put that on the Twitter so you can give it legs. It's getting lots of legs, including from several epidemiologists, so that is a good sign. We are also asking the government here in Ontario to use community care providers to ramp up vaccinations. By now we know that we will have 9 million vaccines in this country by mid-March, more or less. If you think, a third usually comes to Ontario. So for that to happen, we need to plan. Actually, we needed to plan in the summer, but let's plan at least now. There is nothing that we need to wait. The planning must be full tilt as we speak, and then you switch the light, as we say, when you have the vaccines here. No need. My fear always is that we will wait, and by the time you have these millions of vaccines, we still will not be ready to go 24/7 in as many community places as possible, using the current infrastructures that the system is fortunate to have, including primary care nurses and NPs, RNs, RPNs, doctors, pharmacists, the pharmacists infrastructure, and yes, home care infrastructure for homebound people. So people that require nursing services in their home, they shouldn't be needing to go out, but in fact, the nurse, whether RN or RPN, that is coming to care for them in their home, should have the vaccine in their backpack and to provide the vaccination right there and then. And we need to be going on this 24/7 unless we are going to open so many centers that we will not need 24/7, which I am not sure that will be the case. The bottom line is we don't want vaccines in the fridge. Of course, millions of vaccines cannot be given in one day, but yes, we want them very, very quickly in the arms of people. We are all ready to roll up our arms. And so comes our turn. Let's provide the example. I know the topic today is vaccine hesitancy, but let me tell you, the polls already are showing that 60% of people are ready to go tomorrow if it was their turn. So between public health measures of continuing to suffocate this virus and continuing to prevent the new variants to take hold more and more in our communities, between that needs to continue tough, and the vaccine, hopefully we will see the end to this nightmare, because it has been long, it has been exhausting, and it has been very hard for every single person in this country and the world, let alone those frontline providers working especially in long-term care that have not seen a day off, throughout this entire pandemic, and those working now in ICUs for the several weeks and months that has been very heavy. And yes, also colleagues that work in mental health and addictions, etc., etc., etc. It's been a long haul, but I think there is light at the end of the tunnel. Next, so please do sign that action alert that Susan had in the previous slide. And with that, I want to introduce Dr. Cora Constantinescu. That's how they would like me to say about you, Cora, if I was in an Italian or Spanish-speaking country. And she's a pediatric infectious disease specialist in Alberta. I heard her actually in CBC one time, and I fell in love with the infectious way that she has to speak, that she speaks about this topic, and the endless patience that she has to answer questions that some of us will say seriously. And she goes, good question. So feel free to put your questions in the chat. Before she starts, I would like her to share about her dissertation, because she's already a physician, but I want you to share about the good news of the defense on Friday. And I also want you to know that she will go through the entire presentation. So we are giving her a good hour, and if it's a bit more than an hour, Cora, that's fine. But meanwhile, you can post your questions, because otherwise people forget what questions did you have. What question did I have, you will say, right? So put them on the chat, and then Susan and Heather and our colleagues will start to create themes about the questions, so that then Cora can get at the end to all the questions and answers as much as possible. We did hit almost 500, Cora. So I need to write to Dirk that he has big competition. And so all yours, please go ahead.
Thank you very much for having me. It's great. I'm really excited. I have never, my mother used to be a practicing nurse, and I've never addressed so many nurses at the same time. So I'm both excited and incredibly nervous. Let me start sharing my screen to make sure that this works well.
I think you should have permissions. There we go. It's coming.
Yeah, I do. Yeah, let me make sure it's all going to, are you seeing the 2 slides or just 1 slide?
One slide.
Perfect. Good, good. Had I known this was a competition, I would have totally upped my game. So I feel already that I didn't know.
Let me tell you already a secret. As it relates to slides, no competition. Where on you win that one? By gender and by slides. That's that.
Okay, so nice to know I'm ahead. I always like that. I have to say that the slides, I have to thank my colleagues at 19 to 0 who've actually done a fantastic work of trying to improve the look of slides. Otherwise, they look like a healthcare worker made them, you know, the typical white background with the different bullet points, but they've done a fantastic job of taking those slides and making them look so amazing. So it's really nice to be here. In terms of my defense, I have to tell you, I was going to go for the world's longest masters at 6 years, but my family almost made me write a contract that I'm going to put an end to everybody's misery, and I did finally defend it this Friday. So kind of exciting to put that behind me. And my big interest has always been in how healthcare workers and people make decisions around medical decisions and behavior. And I study that within the context of antimicrobial stewardship and prescribing. And I've been studying that in the context of vaccine uptake and hesitancy. And this has been a big passion of mine. We've actually been running a vaccine hesitancy clinic at the Alberta Children's Hospital even before the whole world thought that vaccine hesitancy was exciting and sexy. We used to do it even before then, mostly talking to parents who were vaccine hesitant around their children. So in some ways, this is kind of interesting for us to actually talk about adults about their own vaccine hesitancy as well. So I'll share with you a few things. We're going to Before we can talk about how to effectively discuss these vaccines, we're going to do a bit of a run through just to bring you up to date or where we're at on the vaccines that we do have that have been approved for emergency authorization in Canada, a few bit of contraindications and precautions, and we'll talk a little bit about the side effect profile. And then I will spend most of the time around effective communication and understanding how hesitancy around this vaccine is shaping up in our country. And then we'll go through some common myths and misconceptions. And either we can do that through the slides, or I can do that as you bring up your questions and queries. So here we go. We're going to first talk about the 2 vaccines that have been authorized in Canada for emergency use. And you'll see that I'm using that terminology because it's a little bit different than having been licensed in Canada in terms of the actual process. But the 2 vaccines are both mRNA-based vaccines, slightly different but very similar ingredients overall. They're both a 2-dose schedule. Again, a little bit of a time difference. So the Pfizer product is at 0 and about 3 weeks. The Moderna product is a 2-dose schedule of 0 and 4 weeks. There's a bit of a leeway there and up to 6 weeks in terms of allowing the dosing interval. Pfizer is authorized for people over 16 and Moderna is over 18. Hopefully, as a pediatrician, obviously there's great hope that these will come towards children as well. And I think a lot of these studies are already underway to look at children. So where are we at now? So as of January the 21st, so this is just about 3 weeks ago, over 850,000 doses of these 2 vaccines had been administered in Canada. And in Ontario, 295,000, Alberta, almost 100,000 doses. So getting close to a really good sample of our population. It's still, however, only just over 1% of people who have been immunized again with these 2 vaccines. I tell you, when the vaccine race started, I was the first one to say that we're probably going to have a vaccine quickly, but it's not going to be very good. And I still remember, because I teared up when they actually announced the efficacy of these vaccines, because they're incredibly efficacious. So both the Pfizer and the Moderna vaccine are around 95% efficacy, which is very impressive for a respiratory virus. We don't have a lot of respiratory virus vaccines that are these good. And also, they're not a live vaccine. So comparable vaccines after 2 doses would be something like the measles vaccine, but that is a live vaccine that comes with its own contraindications because of that. So very, really good news when this came out. And what was also really good is the efficacy stayed true across ethnicity and age and race. So again, with many vaccines, we know that as you get older, with immunosenescence, response to the vaccine is not as good. So it was nice to see that in people over 65, and they looked at that particular group as their own subgroup analysis, the vaccine was still very efficacious. If you have to describe how the mRNA vaccine works, really it's like a recipe or instructions that the mRNA has, and that recipe gets injected into our muscle cells and goes into the ribosomes of our cells, where they make a version of the spike protein from the SARS-CoV-2 virus. And the spike protein is recognized by the immune cells, and antibodies are made against it. And then the mRNA and the spike protein are quickly disintegrating. They are gotten rid of quite quickly. And the reason we have such storage, it's a monumental storage attempt to have to keep, especially the Pfizer vaccine at -80, is because mRNA is incredibly unstable. I used to work with mRNA in lab before medical school, and I remember thinking this is going to be the worst thing. So unstable and quickly disintegrated in the body. And we consume mRNA whenever we consume, let's say, meat. You'll eat mRNA, and every minute of every day, our body uses mRNA to make the protein we need. So I say pretty nifty and interesting way of thinking of vaccine. The other thing that's really neat about the mRNA vaccines is that if you need to change the actual recipe, so the actual part of the mRNA, it's reasonably simple. And I heard the makers of Moderna talk about it. It's a bit like they use the cassette tape. It's like dating them significantly. So I'd say it's like a CD player. They've built the CD player, and all you do is you change the protein, the sequence for the mRNA. You just put a new CD in. So pretty neat that platform was already there. And it's also hopeful that as new variants are coming about, they'll be able to adapt these vaccines reasonably quickly. In terms of contraindications, again, it's not a live vaccine. So the list of contraindications is actually pretty short. So we know that the contraindications are severe allergic reactions after a previous administration. So if you've had 1 dose of this vaccine and have a severe reaction, that's a contraindication to the second dose, or a proven immediate or anaphylactic reaction to any component of the vaccine. And you might have heard a lot about polyethylene glycol and polysorbate as being possible. It's been postulated that they're the ones that seem to be responsible for the higher than expected rate of reactions to this vaccine. Not fully shown that that's the case, but that's what a lot of the experts in allergy seem to think at this point in time. There are a few precautions or things to consider before the mRNA vaccines. So if you are actually infected with SARS-CoV-2, they say don't come to get your vaccine at that point because you don't want to infect people. So defer until recovered. If you're acutely ill, so unknown fever, again, is a precautionary measure. Don't come to get the vaccine at that point. The other one is individuals who have received another vaccine in the last 14 days. So this might be relevant to certain portions of the populations because they might have had a pneumococcal vaccine or Shingrix vaccine in the 14 days prior. And it has to do with the fact that they're both non-live vaccines and they can interact with the immune response. So it's not about safety, it's rather about how well you're going to respond to the vaccine. And then, of course, they're not for individuals outside of the authorized age group, even though in the Pfizer study, they did include children 12 and older as well. And as I mentioned, those studies are ongoing. I firmly believe that in order to achieve really good herd immunity, we have to include the kids in this. I'm going to go through some special circumstances and populations with a caveat that we don't have a lot of the information yet, but a lot of studies are underway to better understand this. One of them is, if you've had COVID-19 infection, do you really still need to get a vaccine? And especially in the time of scarcity and not enough vaccine, this has been a very debated issue. Right now, they recommend a 90-day period for people with a past history of disease, people who've received convalescent plasma, and those who have received antibody treatment specifically for COVID-19. And again, it's not about safety, it's about efficacy. And in the time of scarcity, this is something to consider. Different countries in different places will have different recommendations for if you've had a previous COVID-19 infection. Right now, we say it's not a problem to have it, but it is an issue of scarcity, which is important to keep in mind. And the 30-day period, the 90-day period is because we know that immunity can last for 3 months at least. A recent study actually just of last week showed that natural immunity lasts even longer than that. So what about the allergies? It does seem like these two vaccines are more reactogenic than previous vaccines. Maybe 10 times more allergies noted in the population already among the people who've been immunized. Hard to know exactly what those numbers are because a lot of time, because it's such a reactogenic vaccine, as you can get a pretty sore arm, sometimes it's difficult to differentiate between a redness at the site with sore arm from actual hives or an actual allergic reaction. So I have to tell you that this is really, really an area of study. A lot of people are looking into this, a lot from the Public Health Agency of Canada to Canvas and other research studies and public health surveillance that are looking to see how much of an issue is this really. Right now, what we recommend is if you've had a history of anaphylaxis to other allergens, it's not a contraindication to this vaccine. So if you're allergic to peanuts, it makes no sense to worry about having this vaccine. You just go ahead and have it. The only thing we do recommend is that if you have a known anaphylaxis to, let's say, something like penicillin, again, there's not a lot of logic to say you can't have it, but wait a bit longer, about 30 minutes versus the 15 minutes post the vaccine. And where that's coming from is because 90% of anaphylaxis happens within 30 minutes of the vaccine administration. Does this make the most scientific sense? We don't know yet, but it's pretty reasonable and pretty low involvement to just have somebody hang around for another 15 extra minutes as a thing of precaution. Different rates and the vaccine reactions in different parts of the world, which I think has to do maybe with how people think of allergy and how they measure allergy and how they assess these vaccine reactions. If you have a bleeding disorder, do you need to, can you still get a vaccine? The answer is yes. You don't need to pause the anticoagulation. Just make sure you apply appropriate pressure for more than 5 minutes so you don't end up with a nasty looking bruise afterwards. Another big question is, what about the autoimmune and immunocompromised people? Can they have the vaccine? And we always say, and don't you love this, consider risks and benefits. And it's important the reason we say this is, again, this is not a live vaccine. We don't think that the issue here is safety. So if you are a patient who has Crohn's disease and you're on a biological medication, we don't think the problem is that it's a safety to you because, again, it's not a live vaccine. But your efficacy, the efficacy of the vaccine, your response to the vaccine may not be as good because of the fact that your immune system is already being blunted by a different agent. I say, however, that with a 95% effective vaccine to begin with, it would still be pretty good wherever you're at in terms of your response. So worth giving, especially as we know that some of these populations are at much increased risk of the disease if they were to get COVID-19 itself. You've probably heard a lot about pregnant and breastfeeding women. Right now, many experts and many sources say that both breastfeeding women and pregnant women should be offered the vaccine unless they have some other contraindication, such as a previous reaction to an mRNA vaccine, for example, or to the first dose. Ideally, you want to complete both doses of vaccination before pregnancy, but they've actually had a number of pregnant women in various studies. So in the initial study, so in the phase 3 trial, about 46 unintended pregnancies had happened, no adverse effects noted. And the Moderna trial also had a previous study done on rats that didn't show any teratogenic effects in them. And even from the real world data, so VAERS is the American version of that, and CAFES is the Canadian version, where their health agencies are monitoring reactions to vaccines. Over 15,000 pregnancies were reported to these vaccines in people who've had these vaccines without any adverse effects. When we think of risk benefit, we know that pregnant women with COVID-19 disease are at higher risk of severity of the disease, hospitalization, and especially ICU admission. Also, when you look at pediatrics, we look at babies under 12 months of age, so infants are also considered to be higher risk for the disease. So really important, because we're actually protecting with this vaccine two vulnerable populations. And there is some postulation that potentially some of the IgA in the milk can actually be transferred to the baby. So important to remember that here there is no safety signal or concern noted so far, and quite a lot of benefit in these vulnerable populations. Can the vaccines be given to kids? As we mentioned, right now, 16 and over is where we're at in terms of approvals. But I'll tell you what, usually if adults are 95% efficacious in adults, kids are going to be even better responders as a whole. Unfortunately, as we age, our immune system ages with us, and the immunosenescence is noted. We know that in some studies, like the HPV, the human papillomavirus vaccine, if you give it to kids in the 11 to 14 years, they have 4 times the response that if they were 16 and over. So there is a magical, period in childhood that I think the vaccines are going to be shown to be quite efficacious in kids as well. But right now, they were not included in the studies in large enough numbers for us to go ahead and say, yes, we should vaccinate the kids. And obviously, we're looking at, again, scarcity of vaccine. So we need to vaccinate the populations that are at highest risk and severity of the disease. And thankfully, through this, children seem to be spared the severe COVID-19 disease repercussions that we're unfortunately seeing in adults, and especially older adults. As mentioned before, they actually looked specifically in the trials in adults over 65. Efficacy was very similar to those in the younger age groups, which is really, really positive. We know from our flu vaccine studies that is often not the case. So this is really, really good that we actually have vaccines that are good in older patients. Again, both the studies looked at people of color and other minority groups. In the Pfizer and the Moderna trials, about 30 to 40% of the participants were Black or African American, Latino or Hispanic. So vaccines equally effective in all groups. So what are the side effect profiles of these vaccines? As mentioned, we do know that they're more reactogenic than other vaccines that we've seen in terms of local side effects. So most people can expect to feel a sore arm. So it's usually the pain at the site, fatigue, fever that seem to be there, and headache as well. So those are like the big things that I think we can safely say to people, you better expect this. The less common effect effects like enlarged lymph nodes are in about 1 in 100 people. And then of course the anaphylaxis and allergies that we mentioned before that they could only be seen once tens of thousands, hundreds of thousands, and now millions of people have been vaccinated. So pain at the incision site, fatigue, headache, and then fever can also be seen significantly in the Pfizer as well as the Moderna vaccine. So pain at the injection site, more than 8 out of 10. If you're going to say, what can I tell people? So this is how I discuss this. I say, listen, this seems to be a reactogenic vaccine, which is kind of good. This is probably why it's so effective as well. But this is how I think about it. So in terms of the side effects, 8 in 10 people complain that they have a sore arm. But only 1 in 100 say that that sore arm was severely so. 5 in 10 people complain of fatigue and headache, but only 1 in 10 needed Advil or Tylenol for it. So reaction to the vaccine is to be expected, but most of it is mild and easily manageable at home without having to seek medical attention for it. Long-term protection has been something that people have asked about. We don't know yet, but obviously those studies are ongoing. In terms of effects of the vaccine, it's a non-live vaccine, so most effects would be expected within 72 hours. Extrapolating from other non-live vaccines like the flu, we can say, well, we can look for things up to 6 weeks. Not a lot of biological plausibility to be worried about long-term effects. And then I also say, remember, we now know that the COVID-19 disease long-term effects tend to be quite significant. A lot of people can have long COVID or COVID long haulers, and we know that that can definitely impact how people function. Just a couple of slides on regulatory systems and surveillance. And I tell you, in Canada, we probably have the top-notch surveillance system put in place. But this is how vaccine development goes about. And probably this has never been discussed to such a global scale as with these vaccines, where everybody talks about phase 1, 2, 3 trials. So when you start thinking, when a company starts to develop a vaccine, they're in that exploratory and preclinical trial stage. And if anybody asks you why these vaccines were able to be approved, so authorized so quickly, is because this preclinical stage happened very quickly. And the reason it happened quickly is because the mRNA platform was already there. So these people were already working on mRNA vaccines in cancer, as well as other vaccines like in Zika, were being used, some CMV studies as well. So the preclinical part of the vaccine was already done, and they had already, all they had to do was change the CD player in the CD in the CD player. So they were able to do, this part was already pretty much set up before COVID hit. And then the clinical trials happened from phase 1, 2, and 3. Phase 1 is mostly about safety. Is this a safe vaccine, and what dose should we use for it? Phase 2 is when you start thinking, how well is this working? And again, they try to even nuance the dosing even better. And phase 3, which is in thousands of volunteers, is the one where we say, does the vaccine prevent disease? In order for a vaccine to be licensed, about 6,000 to 8,000 phase 3 volunteers need to be in the study. I have to tell you that the Moderna and Pfizer studies had over 20,000 and 30,000 volunteers. So much larger than other phase 3 trials in the past. And again, part of the reason this was so much faster and so much more effective than before is that these pharmaceutical companies thought ahead and spent a lot of their money ahead. So by the time that phase 1 was completed, they were already planning phase 3 sites and trials. Unfortunately, there was so many cases of COVID at the time that because the disease was so active in the population, they could reach their endpoints quite quickly because of how much disease there was. And then in terms of review and approval, there is a scientific review, there is this approval, then there's a distribution vaccination. But what I also want to remind you is that once we're actually rolling out the vaccine, safety surveillance does not stop there. There's this ongoing monitoring and review. In Canada, we have two systems. One is the more passive surveillance done through the Public Health Agency of Canada. It's called CAFIS. And then there's an active surveillance system as well called Impact, where they actually have nurse monitors looking for reactions of vaccines of people who are coming into the emergency department or hospitalized. So both active and passive surveillance being used for vaccine surveillance in Canada. Again, no steps were skipped, but for sure they didn't start from zero because they already had the platforms developed and they were very good at thinking ahead, and all the political red tape and the funding and the grants and all the stuff that you need to spend years on to get vaccines studied, they could cut right through that because of the politicized nature of COVID at that time. And now, and the trials were quite large, a lot larger than other trials in the past. And also Health Canada received and reviewed the data as it was coming in versus waiting for all the data to be passed to them. And they worked really long hours to try and get this done very quickly. But on the safety side, no steps were skipped. And that's important to remember because there's such a rhetoric about how fast these vaccines were developed. Adverse events following immunization, as mentioned, there is this idea of CAFIS in Public Health Agency of Canada. The APHIs are reported and reviewed by Public Health Agency of Canada. And then we also have a Canvas, which looks at the Canadian Vaccine Safety Network that assesses vaccine safety immediately after the implementation of a vaccination campaign. This has been going on for influenza, and now it's going on for COVID as well. This is just a snapshot. You can get all of this from the Public Health Agency of Canada. This is just a snapshot. As of January the 15th, 2020, you can actually see the various API reports and how many. So very transparent. None of this, behind closed doors bit. It's right there for people to see as these API reports come in. And if you just do a Google search for API and Public Health Agency of Canada, you get this. Now we're going to talk a little bit about the high priority groups, and also important to talk about mitigating pain at administration. And I'll tell you why that is important. But first, the first 4 groups based on the NACI's recommendations. So right now, when you see all of our vaccination programs are a little bit different across the various provinces, but they all have these 4 groups at the forefront of the vaccination rollout program. We're going for people who are at risk of severe illness and death to protect them from COVID-19, to protect individuals who are most likely to transmit COVID-19 to those at high risk, household contacts of those at high risk, those who are essential workers, so this is where healthcare workers fall in, and those who are at high risk of infection based on their working conditions or where infection leads to disproportionate consequences. So for example, this is where the Indigenous communities come in. This is a really important vaccine to talk about pain in. We often talk about vaccine hesitancy around this, and I think that's great. And obviously, that's one of my big passions. But what my pain colleagues have told me is that adults are particularly scared of vaccines, and needle phobia and needle fear can exist. And we know from influenza vaccines that you can actually have avoidance of those vaccines chalked up to hesitancy when it was actually needle fear that prevented them from doing this. So this was a meta-analysis that I'm presenting to you about influenza vaccine. 16% of adult patients, 27% of hospital employees, 18% of workers at long-term care facilities had needle fear. So this is a really important factor in COVID-19 vaccine because so many people talk about how sore their arm was afterwards. If you're going to go on any phase group forum of healthcare workers who received their vaccine, people just will talk about their sore arm. So obviously, if you're already pretty sensitized to needle fear, and then obviously this is going to be a big fear. So important to think about pain, especially as you administer it. Give me 1 second. My apologies. So this is from the pediatric literature and how people in pediatrics deal with pain around the vaccine site, but important, especially as I'm talking to nurses about this, and it's important to really consider this because of this particular reactogenic vaccine. So the 5 commitment to pain. One is a create a comfort plan. So ask them what they prefer, like what's their preferred pain management strategies. Use numbing cream, use simple positive language. So this is really good. You know, we're so bad about this in kids. Sometimes we'll say, oh, this will be over soon, it won't hurt at all. But they're actually saying, instead of saying that, just talk about how well they're doing. You're doing a great job at relaxing your arm. And after the immunization, you can say that you did really well today. And I've certainly also learned to do more of this from a lot of the data coming out of ICUs and how you can talk to people about their bodies and how well their bodies are doing. And that kind of positive talk can actually go a long way to healing and recovery. So it makes total sense to me that it would also be applicable to mitigating pain in face of vaccine administration. Using a comfort position. So ask them, if you feel faint, make sure they lie flat. We know this is a major issue with teenagers. And shift attention. So using electronics, slow deep breathing, maybe some small talk, friendly questions. But all these things play a big role in mitigating pain and realizing that this may be one of the reasons we're seeing so many people not super keen to take the vaccine as soon as it's available, including healthcare workers. Okay, so now I will spend kind of half the time on this, and I want to spend the rest of our time talking about vaccine acceptance and hesitancy. Concerns and denial are natural, but denial doesn't necessarily stem from ignorance. So you might have heard this quote, and I paraphrase it a bit, that people don't reject facts because they're untrue. They reject facts because they don't apply to them. So that's really important. And now you might also think it's a funny and strange time for me to talk about this to you, where right now so many of our vaccination programs have stopped because we don't have enough vaccine. And it may be frustrating to people to think about, why are we talking about concerns and denial when there's so many of us who want to get vaccinated and haven't been offered the vaccine yet? But the reason I'm talking to you about this now is because you're in a really, really special and unique position, because you, as a healthcare worker, and especially as a nurse, are really trusted by your patients. And if there's one thing, you know, many things have changed as we go across this pandemic, but the one thing that hasn't changed is that when we asked patients, this is way before COVID, what their number one source of influence was, if there was one recommendation you could have that would enable you to vaccinate, who would it be from? It was that healthcare worker. And this has stayed true through COVID. So the same question was asked to people around COVID-19 vaccines. And again, recommendation from a healthcare worker, most influential source in terms of vaccine acceptance. So what you are going to say and what you are going to do is really crucial. So even though right now you might be fully converted and you absolutely want to have the vaccine and feel frustrated because you cannot have it, you still have a major role to play, and you can still contribute. Soon enough, you're going to contribute to herd immunity, but now you can still contribute to herd influence or community influence, because you can start talking about this to your patients and to your colleagues. Because I tell you, the many calls and texts and Facebook messages I've had from my own colleagues about this, and I'm sure you can all relate that at some point somebody has asked you about this vaccine. So this is why it's important to face the fact that denial and concerns are here. And as frustrating as sometimes that can feel to some of us who are so ready to take the vaccine but cannot, we still have a big role to play. So after that pep talk, let me tell you a bit about the issues with vaccine acceptance. In a totally fascinating kind of way, people were talking about vaccine hesitancy around a vaccine before a vaccine had even hit phase 3 trials. So people were talking about acceptance around this vaccine before we even had a vaccine. And this is what they said before. We said, we're going to have problems with this because it was going to be pushed faster than ever before. Many of the COVID-19 vaccine antigen carrying platforms were new to the public. Production cannot meet the demand. Here we are. Scarcity exists even among prioritized groups. So, I'll confess the selfies on Facebook were kind of fun in the beginning, but now there's a little bit of like jealousy there when other people are getting the vaccine and others are not. And you can feel that. So people are going to have some division and loss of trust associated with it. And then, as we will soon see in Canada, we're going to have more than one type of COVID-19 likely to be used in our own country. And we're seeing that with some of the newer vaccines you might have heard about. So how does Canada vaccine acceptance compare to the world? So this was a global survey of 14,000 respondents from 19 countries. And they said, well, would you take a vaccine as soon as it's available? And this went out from Russia, just over 50% of people saying yes to that, all the way to China, close to 90%. Canada was somewhere in the middle third, but in the bottom middle third in terms of vaccine acceptance. Groups like Angus Reid have actually followed vaccine acceptance and willingness to get vaccinated through the months of this whole pandemic. So in the summer, they started off by asking the question, they followed it at various intervals. So in July of 2020, 46% of Canadians were willing to get vaccinated. By September, that had dropped and people were feeling a bit concerned. But as you will see, there's been a bit of an uptake in terms of willingness to be vaccinated. Most recently, like Dr. Grinspun said, about 60% of Canadians would be willing to take a vaccine as soon as it's available to them. And with the question if vaccine against COVID-19 became available to you, what would you do? And then they looked at it around the whole COVID-19 concern. Are you concerned about this pandemic? And then again, you see the people, even the people who are very concerned, only about 60% would get the vaccine as soon as it's available to them, which is a very interesting phenomenon that you can be very concerned about the disease and yet not be fully ready to take the vaccine. And I'll tell you a little bit about that in terms of what we have learned from our qualitative studies on that particular demographic. And then we also have to think about, and this is a bit, I tell you, I'm no modeler and I don't love mathematical models at all, but so this, you could poke all kinds of holes in this kind of thinking, but I do want to show this to you because it's important to remember that if we have a 95% effective vaccine, we say about 70% of people need to take it for herd immunity, which means they would still have about 3.7 million people that would be at gap. But if we have a less effective vaccine, which might be the situation, then we're talking even more millions of people that would need to be, that would say no with a 60% acceptance, that would need to reach herd immunity. So again, we're talking about millions of people here, not one or two or three. Across Canada, initially, the Prairie provinces got a bad rap because they seem to have much lower acceptance early on in the pandemic than now. But now I would say everybody is similarly accepting of a vaccine. Ontario is about 45% in terms of vaccine, ready to take a vaccine as soon as it's available to them. And healthcare workers may be hesitant themselves. What's really interesting, though, is that the nature of hesitancy is very similar to their patients. So the same questions, the same concerns are there in the general population as there are for healthcare workers. And their knowledge about the vaccine, the safety, efficacy helps to build this healthcare worker confidence. But knowledge is not enough. They also need societal endorsement and support from colleagues, which is where you come in. And it's important to strengthen the trust between healthcare workers and health authorities. And what I worry about from where I sit in terms of vaccine hesitancy and how I approach it, I do worry that as vaccine programs get stopped, restarted, scarcity happens, healthcare workers lose faith and lose trust in their government and health agencies. And it's important because we know that if you lose trust, you're going to be less likely to take the vaccine. This is from Cosmo, which is actually a governmental survey system that's been done specifically around COVID-19. And what they had noticed is that whether you're a healthcare worker or a non-healthcare worker, the same response in terms of whether you were ready to take a vaccine, both around 60%, which is very scary because, as I showed you earlier, healthcare workers are in those one of the 4 prioritized groups. Some healthcare workers are in more than one because they may be indigenous, they may be older, they might be at higher risk of disease, and a healthcare worker in terms of exposure. So it's important to think that right now, the same problem in the population, we're seeing it in our healthcare workers in terms of vaccine acceptance. So what do we know about vaccine hesitancy and how we can do vaccine communication? When you think about this vaccine and the many reasons for hesitancy, they come across the 5 big C's that the World Health Organization put out around vaccine hesitancy. And in some ways, I say there's nothing new under the sun. It's the same old concerns people had before about vaccines, that now they have them morphed into the COVID-19 vaccine with a few exceptions. A big bubble is confidence. So loss of trust in health care, in health agencies, in governments, trust in the vaccine itself, trust around safety issues, so confidence around the safety of the vaccine. And what we know from our social media studies is that people also don't believe the vaccine works, which is incredible to me because we know this is a 95% efficacious vaccine. The other big bubble is complacency. So this is kind of fascinating because you think, well, if you're a pandemic denier or the pandemic is a hoax, it makes sense that you're not going to take the vaccine because you don't believe the pandemic is real. But here's what we've learned. We looked at our vaccine hesitancy clinic and we looked at some of the groups there and we asked them questions around why they're hesitant around the COVID-19 vaccine. And what we learned is that people can be very concerned about the pandemic. They're quite concerned that this is a real deal thing. It's going to affect themselves and their children. They're worried about their safety, but they still won't take the vaccine. And then when we asked them why, they felt so safe in their compliance with public health recommendations that they felt that they were safe in their bubble. We call that group the bubble dwellers because they're people who feel so safe in their masking and their physically distanced ways that they're saying, I don't need the vaccine, which is kind of fascinating when you think about it, because I wouldn't have thought of that as a group that we need to think about and message and understand and tailor messaging to. The other big is convenience. So inconvenience, scarcity comes up, but also inconvenience, it also comes with this idea of is this needed? Can I just live in my bubble for a long time and therefore won't need to actually have the vaccine? Calculation, or where you look for sources of information, very different among the vaccine hesitant and the ones who accept the vaccine. So if you're a vaccine acceptor, you're going to be looking for more mainstream media, and you're going to trust websites that come from the government, that come from the public health agencies, versus social media and more friends and colleagues kind of social networks that the vaccine hesitant would go to for their information. And then the one other really interesting bubble that has been brought forth in vaccine hesitancy was this idea of collective responsibility. So, even though you're young and in the age group where the largest cases of COVID happen, you may not be at risk of severity of disease, but we want you to take it so that you can protect those in the population that are at risk of death and poor outcome. That collective responsibility does not seem to resonate with the vaccine hesitant around this vaccine, because their own personal safety seems to be more paramount than the idea of collective responsibility. The only place we saw it was again in our bubble dwellers who said, well, I feel so safe with my following recommendations so carefully that I think somebody else should have the vaccine instead of me, which is very interesting. But again, personal safety is at the crux of this kind of equation. And if you ask me, what should I focus on? Like, what messaging, what kind of education should I put forward around this vaccine? Here is the gist of your vaccine information. Focus on the fact that vaccines work, vaccines are safe. There is a risk of COVID-19 to self and others. So even if you're not in that high risk group, you could get long-term COVID effects and sequelae. And it's the way out of this misery, which we're all experiencing. And it's the way out of this whole, the effects on mental health, on overdose, on suicide that this pandemic has had on so many people in our society. So they're safe and effective, the COVID risk to self and others, and it's the way out. And it may seem logical and simple, and this is what but you want to say that over and over. So you end with these kind of like, this is the gist of your information. And remember, people make decisions based on the gist of what they understood. So they're not going to remember the little bit of detail you gave them that 88% of people who have the Moderna vaccine have a sore arm. They're going to remember the gist. This is a safe vaccine, but expect a sore arm when you have it. So now I'm going to introduce to you, and I'm going to propose what we call the PROTECT vaccine communication framework. So this is something that I've looked into and kind of tried to think. We did an this is evidence-based. We looked back on the literature and said, if we had to have a short 5-minute conversation, because realistically, this is all we have often with colleagues or with patients or clients, how can we do it quickly and yet on using effective communication strategies that have been shown to work? And then Dr. Noah Ivers has helped make it sound really good. So PROTECT is much better. I jokingly say that when I first came up with it, it used to be called Pop-Up, which nobody would ever remember or take up. But so here's how it goes. So the PR of this is proactively starting a conversation that is presumptive. So even before you start the conversation, you tell yourself that that patient or that friend or that client is going to take the vaccine. So you're not going to go into it as some kind of like discussion of back and forth ideas. Your aim of that conversation is so that at the end, they're going to be ready to accept the vaccine. Then you're going to offer to share your knowledge and about your facts and experience if you've already had the vaccine. So if you already had the vaccine, it's a great time to say, I've already had this, or I just went to a webinar on this, or I've looked through my many patient population and I've picked out the patients that I think are at highest risk and I've thought about this. Can I tell you what I know about it? And then the next 2 letters, the T and the C, are really important. You're going to tailor the recommendation to a specific health concern, but you're going to really tailor it. And you may say, well, how is this new? I knew to address their concerns before. But you'll notice this is like the concerns are the 4th thing on the list you're going to do. The first bit, you're just going to build a rapport. You're going to assume they're going to take this vaccine, and then you're going to address the concern, versus what we are always wired to do as healthcare workers, which is to just address the concern. You're like, I'm pregnant. Should I get the vaccine? You might want to say, focus on the fact that she's pregnant and wants to question about the vaccine, but don't. Step back and go through your whole framework. And when you get to the concern, you tailor it so that it's only about them. So if the concern is about pregnancy and vaccine, don't talk about allergies, because that's not what the question is. Even though you might know a lot more about allergies, or whether you've just read something really interesting about it, focus just on the concern that they had. And then talk through a specific plan. And that will obviously be a bit more applicable once we actually have a clear vaccine rollout plan. And we said talk because of so much virtual care happening today. But if you were in my vaccine hesitancy clinic, what I do is everybody leaves with an actual schedule with a child's name at the top of the vaccine. So you write out a schedule and say, for your child, this is what I recommend. Therefore, in the COVID vaccine, for you, this is what we recommend. So I'll give you some examples. What does a presumptive statement sound like? So it may sound like this. I'm here to support you as you make the decision to take the vaccine. So you're presuming they're going to make the decision. You're not going to say, what do you think? Are you going to take it? That's what we call participatory. But no, you're going to make a presumptive statement. I'm here to support you as you make the decision to take the vaccine. I had the chance to get it myself, and I'm happy to help you get protected too. So there's a presumptive approach. Then you can say, I've been thinking a lot about this vaccine for my patients, and I've been educating myself around the science on it. Can I share some of what I know with you? And then you tailor it. This is why this is an important vaccine for you to take, because you have high blood pressure and diabetes, but your life is pretty good. And because of your conditions, you're at high risk of getting hospitalized with COVID. So we need to make sure you have a good quality of life right now. If you're talking about maybe your single mom colleague who's questioning the vaccine, maybe you say, this is why you need this vaccine, because can you imagine if you get COVID and you get admitted to hospital, how traumatic and scary that would be for you and your child. So again, you're just tailoring this information to them. And then you address their concern, whatever that might be, and then you're going to talk through a plan. So what I say to you is you don't need to know the whole vaccinology of COVID-19 vaccine to be able to have an impactful conversation with a colleague or a patient. You just follow this, and by the time you get to the concern, you've built enough of a rapport there that what you're about to say and how you'd address it is still going to be impactful. And it's going to empower you because you don't feel powerless. You're like, I don't know. I haven't read anything about the Novavax vaccine and the Johnson & Johnson. What if they ask me something about the AstraZeneca vaccine? I don't know all of that. But you don't need to still be impactful to your colleagues and your patients. You just need to have a bit of a plan on how to do it. So now we're going to cover a few of the common misconceptions and questions, and we're just going to gloss over them. But if you have more questions about them and you want more details, I'm happy to cover those. So do vaccines work against the new COVID-19 mutants and variants? So this obviously is an incredibly hot issue right now. And it depends a bit on what vaccine you're looking at. And you need to understand that all of this is still evolving. So we just found out that AstraZeneca, as predicted, has real poor efficacy against the South African variant. So as a whole, if you're going to generalize, it seems that efficacy seems to be reasonably well maintained against the UK variant, but seems to be pretty poor against the South African and likely the Brazil variant as well. There's probably a domestic US variant that's going on that we haven't fully clarified yet, that we don't know the efficacy into. The data are evolving. The one thing you need to know is that even in the ones that didn't seem to work as well, so efficacy was about half in the variants, they still seem to protect against death and severe outcomes, which is still a powerful thing to have. But this is still ongoing right now. It seems that as variants grow, maybe the efficacy is not going to be as good. It seems like the UK is reasonable, but the South African variant for sure, more difficult to go against with the current vaccines we have right now. Do I still have to wear my mask? I wish I could say no to that, but right now, there's not enough evidence to show that this seems to prevent infection as well as disease. Now, extrapolating from other vaccines are just as good at infection and disease. So likely at some point, we won't have to follow all the public health recommendations we're following right now with masks and physical distancing. But right now, we still recommend that even after you've had your vaccine, even if you have COVID-19 disease, you still have to follow all the recommendations as before. And please don't travel after you've had your vaccine, which I know that was the first thing I thought of. I thought, if I get my vaccine, can I just go travel? But the answer is still no. How does mRNA relate to DNA? Maybe if you don't have this question anymore, I think it's been addressed many times, but know that mRNA does not get into your DNA. It doesn't have the ability to get into the cell, into the nucleus of the cell. And then even if it did, we don't have the enzymes to convert it to DNA. So it's not going to change your genetic makeup. Are the elderly at the increased risk of death from the vaccine? So this came out of Norway with some cases where they said, well, look, like we've done it in our very, in frail elderly people, and they had a number of deaths that had been reported after the vaccine. And then they said, could it be that maybe in older people, so the biological plausibility of that was to say, maybe in older people, if you don't feel like eating or drinking after the vaccine, maybe that's enough to actually increase your risk of death. Or if you have a fever, maybe that's enough to actually put you into a worse kind of outcome after the vaccine. So important when you see these kind of reports is to think, what's the baseline rate of death in that population, in that age group. So in Norway, about 400 people die weekly in nursing homes. This is without any vaccine and before COVID. In the US, they actually looked at the CDC reports that had coming in so far, and there was no safety signal. So about the same, the baseline rate of death was similar with the people with the vaccine and without the vaccine. It seems like deaths in this population following vaccination are just consistent with the expected all-cause mortality of this age group. But this is exactly the kind of stuff where surveillance is so important, and how do you interpret these kind of sensational, media reports is also important, how you think about it. Another common one is, does it contain mercury, formaldehyde, aluminum? It doesn't. If you want to know the vaccine ingredients, they're definitely not hidden. Again, a quick search on mRNA vaccines ingredients, you're going to get the different ingredients on either one of the vaccines that have been approved for emergency use currently in Canada. What about vaccines and infertility? So this is something that came out because there was a rumor that the antibodies against the spike proteins might target a protein that seemed to be similar in the placenta of pregnant moms, syncytin-1. However, this all came about of some idea. There was absolutely no evidence that this was going to happen. And there was no data suggesting that these antibodies would actually affect this protein. They're actually quite different proteins. And if that was true, you'd expect that COVID-19 disease would have been associated with increased risk of miscarriage. Interestingly, it's associated with bad outcome for the mom. So moms end up dead, they end up hospitalized in ICU, but not with increased risks of miscarriage. And again, whereas COVID-19 in pregnancy leads to severity in ICU admissions, it doesn't seem to have a high rate of miscarriage. So no biological plausibility to say this causes infertility in population. This is particularly important in some religious groups that have this concern about this vaccine. And then I think this might be the last one. So should I let others go first? Can I just wait a bit? And in some ways, maybe that's reasonable if you're going to have to wait a bit anyways, because we won't have vaccine for you. So if you're in those groups that you're not a high risk group, it's probably reasonable to maybe think like this. But all the people on this call, you're in the high risk group. So keep in mind, we've now had over 40 million people who've already been vaccinated. So you're not among the first. I'd wish we had been among the first, but we're not at this point. So take the vaccine when it's offered to you. It allows for a more efficient process. It only get better and more efficient and more streamlined as we go through this. And we've definitely learned a lot over this pandemic. We sure have learned a lot about vaccinology. My gosh, this has been incredible. And we're learning a lot about vaccine acceptance, how to talk to people about it, and probably just learning a lot about ourselves through this whole thing. Anyways, I'll stop here. Thank you for listening. I'm almost exactly at an hour and ready to take any questions you have.
So first of all, thank you so much. And I wrote to people as you were talking a few minutes ago, listen to the tone, because it's also the tone by which you speak, and listen to the content, and listen to the style. Cora, you don't cease to amaze me. I need to say a chuckling story. So I am in this national group with Cora, but we didn't know who was in the group. In any case, I come to the first meeting and I say to people, we need to have David Fishman, we need to have this, we need to have that. And then I go, and we need to have Cora. I don't remember her family name, but I don't know if you know Cora. She was in CBC. I could listen to her forever. And they said, oh, well, she's here. And that's when we met. But isn't it true? One can listen to Cora for hours and not feel nervous, not feel anxious, not feel threatened. And I think today, in listening to you, Cora, there is one more thing that I think you said that is so important for any professional and even any person, not even health professional, which is you don't need to know everything. What you need is to tailor the message and engage, right? The example that Cora just gave about the mother that is a single mother and what it will mean for the kids if she needs to go to the hospital or even be self-isolated. we have a colleague, and she has been in the media with this, so it's not out of turn that I'm talking about Brigitte, waiting for her husband and for the, immigration to clear up the paper. She's an ICU nurse. By the way, in the Toronto Star today, you all watch that. And she needed to be in self-isolation. Just picture her daughter, right? Just picture that. Like, right? And of course she did it because there was no other choice, was no vaccines, right? The other piece that you said in terms of a summary, let's not think that because we don't have vaccines, we don't need to talk about this, because we will have more vaccines than what we know what to do with. And we will have also probably a plan that is not completely planned. So more of a reason why we will need to say to people, if you are not in the line, but they call you, go, because there will be, I am sure, the plan and the other groups that will be ready to go. So let's open for questions. I want to welcome our colleagues in nursing, of course, but I also saw we have nutritionists, we have physios, we have a couple or a few dental hygienists. That's lovely. I'm not surprised. And we have people from several others from other professions. So welcome to all of you. We're really thrilled that we could open it for you. And Cora, you did surpass the 500, just so you don't get more nervous. Exactly, I will send a note to Dirk about that. And then I have a question. People want the PowerPoint. We can post it, right?
Yes, probably. Let me just double check with a few folks who've also worked on it, just so that I don't.
And then put the cover page. That's fantastic. And
yeah.
What you can do is put the cover page with all the names you want, but you go first, girl, because you presented. So I don't care what others say. You need to go first, you say. And then say that we asked that. And at the end, who to contact if people want either more information or if they have questions or if they want to invite some of you to present, please do.
I'm gonna share my email right now. Sorry, it should have been in my last slide and I forgot to mention that. So here's my email right now. You're welcome to. If you don't hear back from me in maybe 3 days, email me again because I've lost you in the thousands of emails I've received.
And now, are you on Twitter?
I am. Am I very good at Twitter? No, but here I go. Okay. I'm going to give that to you as well.
Very good. So let's open for questions, Susan. And I also put a tweet, by the way, for colleagues before they head out to retweet the reaction of RNAO, the initial reaction to the reopening. It's getting quite a bit of legs, which is always good. And we are putting a statement at around 3:30 that is more fulsome than the first reaction. Go for it, Susan.
Thank you. So many of the questions that were coming into the chat box, you actually answered throughout, but there still are lots. So I'm going to start with a question we had around the vaccine schedule. So there were a few questions about that. If the second dose is delayed, if it's delayed longer than the 6 weeks, the 42 days, does someone have to restart the schedule? What do you have to say about that?
Yeah, so that's a great question. And the reality is we probably don't know a lot about the efficacy when we delay the doses. We never restart it. So when it's a 2-dose schedule, the first is kind of like your primary series, the second is a booster. So you don't restart any schedules as a whole, you just pick up where you left off. Could you have reduced efficacy? It's conceivable. People say that probably...
I think, Cora, we may want to clarify though the issue on the 42 days. I think there is already a bit of evidence that you don't. Correct. I think when Cora is saying it's off-label, like we heard, I don't know if it's true or if it's factual, that some workplaces indefinitely, you know what I mean, indefinitely till March. Well, that's off the 42 days.
Yeah. Yeah, exactly. So the 42 is the one where we know seems to maintain efficacy, but then past that it may not. I have to tell you that from the AstraZeneca trial, which was really interesting, and obviously it's a different vaccine, but they did have a bit of a mishap in terms of their doses and their time to the second dose in some in a subgroup, and some of those went up to 10 weeks, some to 12 weeks between the 2 doses. And interestingly, they think maybe that's why some of those people people had better efficacy. So sometimes waiting longer may not necessarily be worse, but obviously we don't know how this applies to different vaccines. So do mRNA vaccines have to be within the 42 days? Maybe. I would still say don't repeat, just get the next dose whenever it is being offered.
Great, thank you. The next question is about people who may not have been diagnosed with COVID or develop COVID around the time of the vaccine, and you were saying to possibly delay the vaccination. I believe you said maybe 90 days after it had been resolved. Can you speak about that?
Yeah, so if you have active COVID, so if you're in the 10 days of having, and there've been a few cases like that. So, they've had the vaccine and then 3 days later or 2 days later, they actually had COVID. Then we say you stay away while you're actively infectious. So the 10 days of infectivity or longer, depending on your symptoms, don't go to get another dose because the risk of exposing people is significant. The 90 days seems to be coming out of, so right now, let me just say that in Canada, we don't ask people whether you've had COVID or not. We're just offering the vaccine to all and everybody takes it whenever it is. I think in time that might change. And if you look at the CDC and other recommendations, they say you're probably pretty immune the first 3 months after you've had COVID. So it kind of makes sense that if we don't have enough vaccine, should we still offer it to the people with COVID? The problem with, so I think biologically we shouldn't, and we should probably let them wait 3 months at least. The problem is in the administration, the logistics of it. How do you prove that they've had COVID? How do it's just not easy to do all of that. And anecdotally, what we also know is that people who think they've had COVID without actual proven COVID, PCR, have zero serology, which means they haven't had COVID. So there's a lot of people who think they have. So trying to protect and prevent missing people right now is just easier to say whenever the vaccine is going to be offered, you go get it. So I'll give you an example. I'm going to share this about myself. I unfortunately had COVID with my entire family in December. And if it gets offered, initially I thought, well, maybe I should wait to give it to somebody else if it would be offered to me. But I think the reality is our system doesn't have that ability yet. Again, I don't think it's a safety. So many cases where people had COVID and then had it 2 weeks later or 3 weeks later, had the vaccine, and there was no significant safety concerns. It's just an issue of if we don't have enough vaccine, maybe we should ensure that we don't waste it on people who might already be immune. Also, I'm just going to say one more thing about this. In Canada, we haven't had as many cases as countries like the US. So this might be more relevant in the US, where they've had so many more cases that actually they might be saving vaccine to vaccinate the ones that haven't. But for us, is this really going to be significant at the level of the population? Probably not. Safer to just actually vaccinate everybody and make sure at least everybody has some protection.
Great, thank you very much. There are a couple of questions about the fact that this vaccine has not been around for a long time. There are no longitudinal studies. So concerns about, effects of later on in life for a pregnant woman, for example, or.
I want to try it. Let me try it, and Cora will correct me. We will do role play. Good question. I will start because I learned that from Cora. Let's think, what are the chances if you are pregnant of the damage that COVID can do to your pregnancy and to you vis-a-vis the vaccine, right? So that would be where I would start, Cora, that conversation, because people think it's the vaccine or nothing. No, it's the vaccine or getting COVID, right?
Yeah, and even before that, remember to say, I'm so glad you're approaching me about this, and I'm so glad you're planning to take this vaccine. And then you move on to,
Excellent.
Yeah, so again, pregnancy, not a contraindication. Offer it to pregnant women. A lot of value in protecting them from
COVID.
From COVID, yeah.
Yeah. So I think the concern is, what if, and later on down the line, or some concerns about neurological effects. Is there anything more that you wanted to say about that?
So this came, I'm assuming this comes out of Guillain-Barré syndrome and influenza, which has been associated. So we know that influenza vaccine, 1 in a million can have Guillain-Barré following, and that happens within 6 weeks. And we also know it's a contraindication for future flu vaccines. A couple of things to say about that. Influenza disease, 10 in a million have Guillain-Barré. So 10 times more common to have Guillain-Barré from influenza than from the vaccine. No biological possibility believed in the mRNA vaccine and influenza, and Guillain-Barré, the way influenza was with Guillain-Barré. And people have actually looked at this and they don't believe that there would be the same neurological fears from these vaccines as that had been with the influenza vaccine.
Great, thank you. I'm going to move on to questions about side effects. Floaters in the eye, heart rate of over 200. Any comments about that?
Yeah, the floaters in the eye, I have to tell you, I saw this briefly come up, and I haven't looked deeply enough to have looked into this. So I can, if you email me, I can make sure I do a proper search to get you some actual, like baseline numbers and then other numbers. I do believe there was a mention from the Ophthalmology Society about how it doesn't seem to have problems on the retina, like retinal detachment. So I know floaters is not the same as retinal detachment, but maybe contact me and I'll try and do a proper search on that. I don't want to, I never want to dismiss anything. So I want to be open-minded and look into it carefully. Heart rate over 200 for sure. I think, listen, this is going to be an emotional experience for everybody getting this, it's, so first of all, there's a lot of anxiety, some people going into it. There's pain. And it's also, my sister works in long-term care and she was offered the vaccine. And she said afterwards, I cried and I looked around me and everybody was crying.
I love it.
And then she said, and then people who and he said, including the security guy who hadn't had the vaccine and the nurses who were giving the vaccine who hadn't had the vaccine. And it was such an emotional time. And I'm not saying that's it, but for sure, you can have increased heart rate. That has been reported, increased heart rates post-vaccine. Nothing, though, however, that should, you're not going to end up in emerge. Obviously, however, tachycardia is a symptom of anaphylaxis. So you have to put it in perspective. Are there other symptoms? Is there difficulty breathing? Are you seeing hives? So when you see that, you have to think of all the other considerations. Is this part of anaphylaxis? But alone, it has not been associated with any cardiac effects like putting you into SVT or VTAC or anything like that.
Great, thank you. I'm going to ask,
I think that is a very important question here, Susan,
sure,
from a staff that says, I don't do well with a flu vaccine, so I'm worried about the same with the COVID. Excellent question again. I think it will be great to hear from Dr. Cora the mortality rate that people have to COVID vis-a-vis flu vaccine and the risk of not taking versus not taking the flu. I'm not suggesting don't take the flu, but I'm suggesting COVID is a bit more serious even.
Yeah, and I hear you because I used to kind of like be like, oh, come on, like nobody has, the flu vaccine is so well tolerated. And then I had it 1 year and I was just, it was really tough the 48 hours afterwards. And I felt a bit like, maybe this was a lesson in humility. I think, that, so first of all, there's not a lot of same ingredients between these two. Okay, so it's very possible that you're going to go ahead and have your COVID vaccine and actually not have a reaction. And then some people get all upset. They're like, I had my vaccine, I didn't even have a sore arm. Doesn't mean my immune system didn't work. And it's conceivable because there's not a lot of cross reactivity there in terms of ingredients that it's going to be, you're going to have no problem. You may also be a person who's going to have a reaction from it. So a couple of things to say to you. One, you can maybe try and plan it on a Friday or when you don't have to show up to work the next day. So think a bit about that. Tylenol and Advil, fine to take after the vaccine. So don't take it before. We believe there could be some blunting of immune responses before, but just take it afterwards. And you can take it preemptively if you're worried. And then at least you say, okay, I have some Advil or Tylenol or something on board if I do get a reaction. And again, I tell you, having had COVID and having had even what they say mild COVID, like this was not we didn't end up in hospital, thank God, with it. I don't wish that upon anyone. I'll line up for my vaccine as soon as it's being offered, and I'll take whatever body aches or fever or whatever.
Not to scare people, but I do see some are online even. We have had several nurses that I'm directly linked with that had COVID and were not, well, one was hospitalized, the others were not. It was no good. And to this day, it's not good. It's not just that it was not, to this day, it's not good. So yeah, I think people need to take it seriously. I think we underestimate because of all that happened at the beginning. You know, here was Trump, and then he was out there, and Bolsonaro, and those all famous people, and they were out there like nothing happened to them. Well, they don't say the same about the ones that died, but many of those of other politicians actually are not here anymore to tell even the story. But I can tell you from our own colleagues, I have been in touch with several, and it's tough. They're having a tough time.
Great. So can I proceed with a couple of more questions, and then maybe I'll see if Heather has anything that she wants to raise based on the chat box. And I also just want to point out that you are using the PROTECT model or framework when you're answering, which is great for us to see in action. What about the vaccine being developed using aborted fetal cells?
Yeah, so great question. So what do I have to say about that? So there are many stages where cell lines from aborted fetal, and these are elective abortions in the 70s and 80s, and fetal cell lines. So the fetal cells were used to produce cell lines. Since then, there have been no more aborted fetuses or any tissues, but the cell lines propagate. So they use the cell line that they propagate in the lab. I used to work on a cell line doing some cancer research before medical school. So these are human cell lines. And but again, this is not the same as fetal tissue. So I'm just going to say that first. These are lines that are propagated in the lab. There are many stages where you can use cell lines, so fetal cell lines. So they can be used in the development, they can be used in the production, they can be used in the manufacturing component. So some were used in the, actually pretty much all of the vaccines that are now being looked at, and even your vaccines, but for sure the mRNA vaccines have had some use of cell lines early on in the design process, not later in the production process. This is why many religious leaders have come out. So the Catholic Church has made a stance on this. A lot of the Jewish leaders have made a stance on this as well. They say, go ahead and have the vaccine. And they've kind of given that kind of blessing or approval to use it because that it's quite far removed. So no fetal tissue, but can we say no fetal cell lines have been used? That would not be correct because most have had some use, usually in the design stage. So pretty early on in the process, not in the actual upscaling manufacturing stage.
Great, thank you. That's an important question to answer. If someone passes away within 10 days of the vaccine, are we looking into this?
Yep. So any of these reactions get reported. Now, obviously, sometimes it is up to the family doctors or whoever hears about this to report. There is an online reporting system for Public Health Agency of Canada. The other thing to tell you all is that something called the Special Immunization Network is it's a Canada-wide network that looks at reviewing severe reactions post-vaccines, all vaccines, but now they're ramping up to do a specific one around the COVID-19 vaccine. So to look at all severe reactions, it's really important though that every one of those cases get a proper medical review because you want to see what else has been there. Like I'll tell you, part of my residency training I did a few weeks at the Public Health Agency of Canada looking exactly through this, through APHIS and reviewing them medically. And there were so many that had fevers or febrile seizures. And then when you look carefully, they had also had an ear infection at the same time, or, some other way of explaining. So it's really, that taught me that it's really important to make sure you look at the whole case, you review everything. And I think that would also go back to one of your other questions that was asked, which was long-term effects. For sure, these are still being looked at. So if somebody was referred to my clinic that said, I have this child who's developed encephalopathy a few months after the vaccine, I would still review that, fully. And people still do that because the rare in the rare effects, you want to make sure you've looked at carefully. You want to learn about them. You want to be able to think how to prevent them and so on. But even in the causality, so looking to see whether this has been caused by the vaccine, a great review has to go into it. So I think that's reasonable. It should definitely be looked at, especially if it's a death. And I think that's how a lot of these Norway deaths came to be. Is some of them were not right away. Some of them were, days later they happened. They were actually looked into, and there's a whole investigation into that right now going on in Norway.
Great, thank you. Heather, I just wanted to see if there was anything you wanted to.
Yeah, there's quite a number of comments, just trying to keep up with them in the chat box, but certainly, Dr. Cora, there's been lots of comments about, and thanks to you for sharing some of the strategies that you utilized to approach these discussions. And we did have a question earlier about those nurses. In this particular example, a nurse works in a dialysis unit, establishes relationships with the patients very quickly and early on because of the frequency with which they have direct contact. And they're just wondering if you've got any suggestions on how to encourage her colleagues and myself to not give up on the conversation about the COVID vaccine if the clients have actually decided that they initially don't want to have one. Any suggestions from you?
That's an interesting thought. That, I mean, you can tell I'm an infectious disease doctor because I mostly only see patients a couple of times, and then we don't have a significant chronic population. It's an interesting thought, and I would urge that person to actually maybe script one or two statements that they have whenever patients like that come in. So one thing might be, I just had my vaccine. Have you given more thought to going ahead and having yours? I think bring it up all the time. We know from smoking cessation and, the pre-contemplation and contemplation and action stages of where people are in terms of behavior change, that people can be in different stages. And if anything has shown us over this last 6 months or 9 months of this pandemic, is that vaccine acceptance rates have also changed. Mm-hmm. So is that patient maybe in your population that has now all of a sudden changed their mind about it? Or who knows, maybe they've had a closer call with COVID than before, and so on. And it's important to explore, and if they're absolutely like, no, it's important to explore why and to try and document that, because as you think of it more, so, if it comes about recommendations, if it's the bubble dwellers I was telling you about, the people who feel so safe, in their bubble, it could be that if those ease, then they might have a different sense of risk to themselves, risk perception. So I would say, absolutely, you should bring it up every time. Make sure it's still somewhat presumptive without seeming disrespectful. So that's the part where you have to be careful. So, you don't want to say maybe, hey, have you changed your mind? You might want to say it in a way that still is clear to them that you're opening the discussion and they can share it with you. And if there is one thing that I've noticed, is that, as you probably know better than I do, that your clients and your patients, it doesn't just take one attempt to get people to change their behavior, their lifestyle, so on. It takes many attempts, and it just takes a lot to show them that you're there for them. And even though they've told you no before, you're still there to listen and have the conversation again and again. And I think that act in itself is enough to build trust. So for sure, I wouldn't give up. Just maybe script how you would say it so that you're not caught unaware or on a bad day, which I've been caught before. So then they come through there and you're like, oh, I've just already had a bad day. So you just have to be careful that you script that, so you say it in a way that's still ready to say, I'm ready to support you as you're making this decision.
Great, thank you. And I think you
Yeah,
touched on.
and somebody put in motivation interviewing. Yeah, that's
Yeah.
very helpful in that case as well, especially if you've got more time. So we did use some of the motivational interviewing techniques in our Protect, the part where you offer and then you're kind of addressing the concern. I think motivation interviewing is fantastic. The problem is most people don't have a lot of time, so they don't have a lot of time to explore that, but for sure use a different methodology with especially the more resistant to vaccination populations.
Great, thank you. And I think that addresses the second question I was going to pose to you, is about the work that you've done in your vaccine hesitancy clinics, and what might have you done in terms of research to look at changing people's attitudes. But I think you've spoken to that in your last response, so thanks for that.
Great. Are you okay with a few more questions?
Sure, bring them on if people still want to hear me talk.
I'll ask one. I'll just read it out. How would you approach uncertainty about continued transmissibility to others without deterring those in their safe bubble, from deciding on getting vaccinated?
Yeah, so that's a tough one, because even I have a hard time with that. I'm like, come on, we finally have a vaccine, surely. So this will change with a few things. First of all, right now they're doing the studies to see if, so this is the difference between preventing disease and infection, right? So you're saying maybe you can still have the vaccine, but still have the disease, still have the infection and can spread it to others. That's what the difference between infection and disease is. How do I approach that? Say, I think things will change. So as we're learning more, and they're looking specifically at this right now, especially in the new studies, in the new phase 3 trials, they've looked at this, they've actually done PCR tests on people. I think that will change and we'll have more information. The second thing is, if you look at other vaccines, they prevent both infection and disease. So I think it's going to work for preventing infection as well as disease. It's not hopeless, because sometimes people said, oh my God, I thought I had finally seen the end of the light at the end of the tunnel. And now you're telling me there's no light, but I actually think there is. We're just being very cautious. And then the third thing is, once we have enough people vaccinated, we're going to take a bite out of this outbreak, enough so that if we can bring cases down, then inevitably public health recommendations are going to change. And this is where people say, oh, COVID will be with us forever. Sure, that might be, but it's different than having 2 cases a year of COVID, or 10 a year or whatever, without the same fear of high mortality like we did before, because all those people have been protected, versus having, 1,500 cases a day. Very different approach.
Great, thank you. I've got some questions about vaccine administration. So one person is asking about a Z-track injection to make it less, so it's less painful, or mixing it with lidocaine, maybe injecting in the buttock, or having someone move their arm gently to offset pain in the injection site. So any thoughts on those questions?
Do I have thoughts? Yes. Do I know anything about it? No, because I don't administer vaccines. I've maybe done 5 in my life, and that's because of different circumstances. Nurses are so much better at vaccine administration than I could ever be. The buttock, you can hit a few nerves there that are a bit more difficult to get than the arm. And also, it's not easy to walk if you have a painful buttock. A lot easier to just, maybe more debilitating than having an arm. Can you? I'm sure you can at the end of the day. I don't think you should, though, because the thing about these vaccines, especially the mRNA ones, you have to be so specific. Like there's a very tiny bit amount of vaccine you have to take in. You have to be so careful. You don't want to waste any of it. That I would not experiment with different locations. And the fear for lidocaine, I hear that it would be nice, but I would worry about the stability of that mRNA vaccine with lidocaine. And until the manufacturers have come out and said, yes, you can do it, I would not do it at all, because the stability is such an issue. And there is a big, the onus is on us, if we have this vaccine, to administer it well, successfully in everybody that we can, and to think that somebody thinks they're vaccinated and protected but they're not is also a major problem. So I would say stick to the rules on how to do this very carefully, because they're so finicky, these mRNA vaccines. So finicky. But probably an experienced nurse can answer that 20 times better than I can.
There might be a whole flood of responses in the chat.
Yeah, please do not hesitate. Correct me.
Thank you very much.
I almost wanted to say a tongue-in-cheek thing. Can you get one in your buttock? Maybe if a doctor administers it, like, I don't know. But maybe I shouldn't have said that. It is being recorded and live. But anyway, so yeah, don't hesitate. Correct me on administration.
Great. I'm going to ask a question that I think would appeal to a lot of people. Any recommendations on how to communicate to large groups as opposed to the one-to-one communication that you're suggesting?
Oh, yeah, that's a tough one. We think about it a lot. I still think you can tailor the information. So the more you know about the group, the better. I don't think you can communicate the same way to different healthcare workers even. And even within the same profession, if you have physicians, I'll give you that because I know that group reasonably well. You may have very different vaccine hesitancy among, let's say, pediatricians versus some other specialty. And I don't know, but for sure what we do know is that vaccine hesitancy across different healthcare workers is not the same. Some people have different levels of hesitancy, and some people also will need different messages, especially more tailored. Keep in mind that just because people are healthcare workers does not mean they're incredibly fluent in English, and we may need to speak in a different and communicate in a different language. What I think is a good rule of thumb is, this is not a good example because here I am as a physician talking to a lot of nurses and other healthcare workers, but it's also a good idea when you're trying to change behavior as a group to have sources of influence for that group. And whether nurses turn to nurses, use nurses to send the message, or whether it's religious groups, so you may have some certain healthcare worker groups that may need, let's say they tend to be from a similar ethnicity where a certain religious leader is very important to them. I think that's how we can tailor the message. So use the people that they trust and that they want to listen to. And I had to joke because obviously, but I'm really excited to talk to nurses. I learned so much more because the questions are different and it built me up. So don't stop it. But again, like when we message, it's important to message from people that people trust. That has stayed true, is the same, and still tailor it. Talk about how it's relevant to their practice. Again, facts are not, people don't reject them because they're untrue. They reject them because they don't apply to them.
Oh, thank you for that. And that's really helpful.
So I like that final statement that Cora made on listen to people that we trust, because Cora, we trust you. So here I have a deal for you. I think we will have a fantastic one in mid-March when we will have that humongous numbers of vaccines, of having you with your competitor, Dirk. Hey, no, I'm serious. He will love it too. And I think it will be beautiful to really look at both perspectives, right? Because for him to give us the rollout again, and for you to remind key tips on convincing people, then on engaging people, because we will not know what to do with the amount of vaccines. The politics will be out of it finally, because there will be so much vaccines that it will be good to hear you with the latest again, for us to be like an army helping people to get the shots in the arm so we can get into the good weather with less concern than now.
Yeah, exactly. You are an army. And I think that's, the call to action from all healthcare workers, even if you're not into the vaccine delivery, even if you've not been called on to have a vaccine, you still have a lot of influence. And don't forget to use that and practice talking about this vaccine to your friends and colleagues. Sure, I'm ready to come on in March. I would love to have this discussion when we're drowning in vaccine. That'd be lovely.
Fantastic.
Our next webinar is Monday, March 8th. So we'll stay tuned for details and confirmation, but that is just so people are aware that that's the next one. So Doris, where do you think we should go now? We're at 3:47, coming close to the end of the session.
I think I do have a question for Cora, not related to the vaccine hesitancy, but the vaccine program in Alberta, if I may. So let me tell you, number one, what we are proposing in Ontario. In addition to the usual, I don't know if in Alberta they all went to the hospital on the first wave, but it was quite a bit of a fiasco here with the best of intentions. And even this weekend in one of the nursing homes, I mean, it's unfathomable. They call board people and their families to get the vaccine. All the wrong things that should not happen. You know, in times of crisis, I'm not surprised. In times of crisis comes the best and the worst in some situations. But nonetheless, where we are pushing as a nursing community, and actually also with, in some instances with the docs together, is to really engage primary care and to engage home care. So to really leave hospitals for what they are absolutely best, which is to take care of very sick people. Because I know in Alberta also they're pretty overwhelmed, but so are here, pretty overwhelmed in ICUs, etc. And they shouldn't need to be dealing with something that is not their bread and butter, right? So we are getting good traction in relationship to primary care and pharmacies being mobilized. And actually there is a project starting now in home care with a mobile clinic for homebound people. So that comes all as a result of some of the push that RNAO is putting with a few other organizations. Tell us a bit, what's the rollout plan in Alberta? If you can.
So you know, I don't know much about the rollout plan in Alberta other than what's being out in the communities and you know, in the media. I do know that there is a push to get primary care physicians, and I know the Alberta Medical Association is working hard to get them involved. Alberta is a bit different because whereas in Ontario you can have vaccines in RN run clinics in you know, family medicine. In Alberta, historically, vaccines have always been given by public health. I agree with you, though. I think involving primary care physicians, pharmacists, nurses into delivery is absolutely crucial, especially as we will get vaccines that will not require minus 80-degree storage facilities. So I think that's the right thing to do. I know a lot of groups are already involved in that. It's not my thing. You know, I'm a pediatrician, I'm an infectious disease specialist. You know, if needed, I'll be there to deliver vaccines, but I think there are a few other people
I'm sure
ahead of
you
me
know how
who are
to
going to
do
be
that.
much better. Well, I don't know. So I think you're on the right path. I think there's a lot of stuff going on in Alberta, and I encourage you to you know, reach out to the same kind of equivalent associations in our province as well. Yeah.
To us, yeah, that's good. That's good. Yes. So of course, public health, by the way, I didn't mean to. Public health, in our view, the entire vaccine rollout should have been planned by public health. You know, not in any case. That's wave one. Wave two will be public health, I'm hopeful. And with the, of course, with the delivery done by not only public health, because they don't have the capacity, but primary care and home care, etc., and pharmacies. Fantastic. I don't know if anybody else has any questions, Susan, or if not, we'll let Dr. Cora, that's your new name, Dr. Cora, go.
There was a request for your email again, which I was just scrolling through, and I think it's kind of lost in my thing. So someone on our team, maybe we could just put that in the chat box again. And then we'll confirm with you about posting your slides, and the recording will also make available on our website, because you did answer most of the questions, and then there, for additional questions, you're inviting people to connect with you. So thank you very much.
And I am asking everybody to tweet that thing, getting more and more traction, so that's good. And let's remember, all of us, behave according to the rules, ladies and gentlemen. Not big parties, not small parties, not medium parties, but big mask, medium mask, depending on your face size, physical distance, not going shopping until we have the vaccines, and then roll up the sleeves and get the vaccine and converse with your families, with your friends, with your neighbors, and demystify the vaccine, I would say, demystify it. So thank you very much, Cora. Fantastic presentation. Everybody's just, let's ask. So she can go with the full-blown bravo. Let's ask 0 to 10. Where do we put Dr. Cora?
I'm going to take a picture and show it to my family. I love how you were ready to listen to me for hours. If only my family could listen to me for hours. I'm going to put that in, being like, look.
Look, I asked 0 to 10 and they gave you 100.
Definitely the best audience so far. Thank you so much for having me on. I really appreciate it.
You're going up by the minute. You need to tell your family not to put you in the what do you call the trading? You are going up by the second.
That's right. You know how kids and love to listen to their parents lecturing them. Maybe I need a PowerPoint next time I try to do it.
That's better than one day my kids answered to my husband. This is years ago. Image in the television comes here. We have seen her before.
That's really cute. Well, thank you so much, everyone, for having me. I really appreciate that.
Do we want the picture, all of us together? Is Madison around? Madison, can we do a picture?
Yeah, I'm here, Doris, but we can't see panelists, so it'll be you and Cora.
Oh, that's boring. We want more.
Here, but why don't you two smile so I have a nice picture of you both?
Okay.
Great, thank you.
Perfect. Well, thank you so much, everyone. Have a really nice day and a good week. Bye-bye.
Thank you. Thank you so much. Take care. Thanks.